not saying my feet are ugly.
No,
Is that what she said?
Can I just...
No, you're going to take it.
And you've got feet like Angelina Jolie, have you?
I don't know.
I think she's got crappy feet from wearing shoes, like...
Pardon?
She's probably got crappy feet as well, hasn't she?
Gillian,
Not Eddie, I meant Angelina.
Like posh guys.
When I did radiography, I think it was my first week into the course, we went to see ultrasound and I just thought, I want to do this.
Yeah.
Because you're an independent practitioner, you know, I've had my own referral list, wrote my own reports, and I just like that independence.
I like this. I find this really interesting.
The thing is, you know, often you get women referred for
pelvic
pain and they say scan the ovaries, and then you think, wait a minute, that ureter looks, you know, enlarged, and you don't, and you see it was a UTI. And they got, you know, referred pain. So again, with ultrasound,
it's like a detective story all the time, isn't it?
Because
they come in with differential diagnosis, and because I worked in the nurse many moons ago, but I used to work in theatres as well. And one of the things they used to come in because you didn't have to do as many scans, and you'd come in and they'd have a long list of what it could be, and then you'd look somebody up and you'd be like, I always stood there handing instruments, but you know, they'd it'd be like, oh my gosh, that's what it is, and it was that would always intrigue me that you would.
And I would always look at patients' notes because you know you can say, you know, scan the gynae on the left ovary, but when you look at the history and you think, oh, actually, I don't think this is ovary, I think it's this, and you know, there'll be a mass over here, or you know, and with gallstones, you know, you can get pain in the left shoulder with gallstones. People think it's a heart attack, so it is interesting. But hence, you know, I must admit, you know, sometimes as radiographers, it's like something at the end of the foot, just a couple of views. And it's very, very interesting.
But you're going to get people at the end of the lecture saying, just have a look at this.
Oh, yeah.
On the back. Yes, just
my ovary.
The worst thing is when you've got somebody that had something really bad and you can see it and you can't say anything, and that must be horrible.
Well, you see, I because of my level that I was at, I would and could.
Would you tell them?
Yes, yes, you can say, look, this doesn't look good, or it looks sinister.
That's the thing that
I've been told many times when I had the cyst of my, I had the ultrasound biopsy, guided biopsy on my breast.
Yeah.
They told me straight away.
That it was good or it was bad?
Bad. They need to send it off. Yeah, but it was good at that.
Was it? Oh my gosh, you know.
Been taken out.
But I think people have to know.
They just worry until they get that. Until they get.
You know, but I had an ovaries ultrasound again, and the radiographer, I don't know, it was a consultant who was doing it. She said, "Oh, poor you, you're not gonna have babies." Already. That's what she said. Yeah.
But is it true? It's not true, is it?
Yeah, it is.
Oh my gosh.
No, I might have. They said no. I need to go on there. But you know, she shouldn't say that.
No, that's a bit.
When we scan, I can either scan with the person in the prone position, which is more uncomfortable for you. But it depends what we're looking at. So I know Colin this morning said he always scanned Achilles.
Hanging,
yeah, which is fine because you've got easy access, and also the foot's always in the same relaxed position. Because obviously, as you know, we can have tension or. So it's always difficult when you're scanning, but I tend to sort of put it in that sort of position.
I was just going to say that.
Yes, yeah.
Okay.
You wouldn't need to do that.
Can you just move that wire from the top of the
Yes,
screen?
I will, yeah. It's my little pen that's for putting markers on. Can everybody see that? Can you see that as well? Okay. So, I've got the probe in what I call longitudinal position. So it's like that on the sole of your foot. Okay. So for me, it's like looking in at the side now. All right. So the sole of your foot is up here.
That doesn't make sense. No, it doesn't. No, this is what confuses. I need that to be turned. So
I'm glad we're seeing this though. Now,
yes. And down here is the bony arch of the foot. Okay.
Right.
So I'm looking in at the side.
So I need to look at it that way. Upside down.
Okay. Now, you see, this is how we image, but as podiatrists you might work the other way because you're looking at the foot like that, aren't you? Yeah. So again, part of learning ultrasound is to orientate your mind. And when I'm scanning, I just get lost. I can see things in 3D. Right. But it takes a while to do that. So, if I slide down to the back of the foot, we're going to see calcaneum coming in here. There's calcaneum now. Okay? Yeah. And I'm going to come back up. So, the arch is just a little bit deep there for the frequency we've got. Okay. I've got the lower frequency probe here. It's around about 5 to 7.5. That other probe I showed you is 10.5
So it's
to
the
12.
probe that changes the frequency. I
Yes.
thought I thought there would be a dial somewhere.
No, it's the probe. Now, what used to happen is, you used to have about 10 probes. So you used to have a probe that was 3.5, a probe that was 5. What they've done now is combine different frequencies and probes. So I've got a range here. What I don't know is what it's actually listening to. But as long as we're getting a reasonable image in terms of depth, I can alter some things.
So it kind of works it out for itself in the probe?
No, I've chosen this probe
right.
because what we want to do is look at the depth of the tissues, because I'm looking
But
at
you said there was a range of frequencies.
This is a range of frequencies. What I can do is select the ones I want to listen to. Yeah, yeah, sorry. Yeah. So, calcaneum is here. Okay, so then we follow the arch of the foot. Now that's too deep for this particular frequency, so we've got the arch of the foot here. Okay, so we're metatarsals here. Okay, follow this up.
So it's these arrows here, so for each one, that looks there.
So again,
No, there's not much.
So that's fine.
Is that bone at the bottom?
that's the bone at the bottom.
That area there,
Okay.
there's not much.
I'm just running out of gel, which is what usually happens.
That one is abnormal. You see the lines. That's and that one is lots of
Too complicated.
So this,
Now I'm really
This
confused
is not
because,
like the medial arch.
because now it's not upside down.
So
I'm
right,
sorry.
I'm in the middle now. It's longitudinal. Okay. This is the sole, the foot. This is a bony prominence here. What do you reckon that is?
Is that a metatarsal head?
It is a metatarsal head. Yeah. So if we go over to the first metatarsal head, there. Okay. And I flex the toe. You can see flexor lucis longus.
So it's giving you the picture down, isn't it, from the end of the
Yeah.
probe?
Yeah, it's just going that way.
Yeah,
Yeah.
that's your
but it's kind
picture.
of, yeah, we're
So
looking
if
at
I
it.
go into transfer section, what we should be able to see is this probe. Just a minute.
Molten
Because,
tumour.
yes, so we're looking at the metatarsal head now. Because they're not all level, it's you've got to start doing what I call oblique sections. Okay. Now there we are. So I've turned the probe slightly oblique. So this is where it's difficult to follow because they're at different levels. So you can see the probe slightly angled. So these are metatarsal heads. So we will be able to look for Morton's
Oh
neuroma.
right, it's between seconds and...
If you wiggle your toes, what do you think?
Yeah.
Shall I wiggle them?
Wiggle your toe. Yeah, so if we do a... And you can see the tendons here quite nicely as well. Okay. Now if I come down... Now there's our flexor digitorum brevis. Okay, largest muscle in the foot. Would you agree? Yeah.
Is that normal?
And then it looks normal. And then if we wiggle our toes, we'll be able to see some of these tendons coming out from it. So these are tendons end on, so they're coming towards us. So it's the loaf of bread scenario again. Okay, one slice at a time. So one slice at a time. There's a nice tendon here. Yeah. So it's probably third. Yeah.
Gosh, isn't it fabulous?
I can see a heart there.
Oh no, don't tell me it's twins.
And I'm just following it back now down to calcaneum. Okay.
Twins, isn't it?
I know. 'Cause that's what you used to sing, isn't it?
Now, because we're set up to look at flexor digitorum brevis, we're not set up to look at plantar fascia, but this is plantar fascia here. You know, in the images I showed you, because it was set up, it was much more prominent. This is set up for looking at flexor digitorum brevis, but the plantar fascia is up here. So what I can do is so what you could do if you wanted was to take sort of relative thicknesses between plantar fascia and then flexor digitorum brevis if you wanted, so take your measurements. So how would I describe this bit here?
Right, it's bright, isn't
Bright.
it?
It's bright, so
Which means it's...
Hyper.
yeah, I would,
So it's
it's
less...
probably normal, so I would probably say it was echogenic, just echogenic,
right,
but
okay.
yeah. And this area sort of here,
That's dark, isn't it?
yeah.
Hypogenic.
Hypoechoic.
Echoic.
Yeah. And then an area that I didn't touch on before is when it's completely dark like that, you can describe it as anechoic. And A means without, doesn't it?
So, yeah.
Anechoic is without echoes.
And what are those?
Fatty pads.
Are they fatty pads?
Well, not necessarily, because the angle that I've come in at
Right.
means that the beam has been attenuated.
Right.
Okay, so we've got another one of these structures here, but because it's oblique, we can't see it on this image, but I know it's there, and it's blocked the ultrasound, so in
Behind
fact
it.
this is normal tissue, but the echoes haven't got there.
Yeah, because it's behind. Yeah, it's behind
That's
it.
it.
Yeah. So it's like a shadow.
That's right. So what you must do is never report on other people's ultrasound images, okay, because I've seen people who've scanned gallbladders and have missed gallstones, and there's a normal looking gallbladder, and the gallbladder's normal, and you miss the gallstones. So you must always do your own scans. And the thing about ultrasound is it's a dynamic intervention. It's not a radiograph. So just looking at that one image there doesn't tell you a great deal. The image is there as a recording of what you've done. So you must always scan.
I think we should go check.
So there's plantar fascia, that's lovely. Look at that plantar fascia there.
How's it look?
Lovely.
So if we get that in the exam, we can put down, when they say, what's this? You say, we
Well,
can't,
we can't,
say because we
we
haven't
didn't
done
do
the
it.
scan.
We would not like to commit ourselves to. Yeah.
How does the horse's mouth? That's what
Yes,
I'm
I'm
saying.
not. I'm not.
Are we
Yeah,
doing a
well,
different
as
tutorial
noted
for
by-
exam?
And I quote.
Professor.
Are we doing a different demo for our group, or are we all joining together now?
No,
No.
we'll do a different...
Oh, right, okay.
Yeah,
Just that we
Just so we're doing different
Yeah.
things, that's all.
that's okay.
The alien in my foot.
Yeah. So coming back to flexor digitorum brevis again. So what I wanted to show you was right over on the lateral side of your foot. Yeah. So I'm in longitudinal section, so side on. Okay. Coming across medially. Now, if I keep the probe straight, see, we're going to lose it. That to me is an awful image. I do know that people have looked at this and said, oh, there must be something here because we've got this shadowing. Yeah. I just know it's the way we're scanning. So I could take that image now and say, okay, what do you think this is? And you go, oh, I think that's a neuroma or some sort of neurological problem. No, it's not. It's because we've not got the probe aligned to the tissues correctly.
You need a lot of experience.
Yeah.
You do. You do.
Skill.
But, you know, if you were interested in it, then, you know, it can tell you a lot. And of course, flexing your toes as we go along. Oh, look at that. This is lovely here. Look at this.
We've got a lovely
Got a nice plantar fascia.
Do you know something that's made my day? That has.
Look at that. Look, this is plantar fascia here. Look.
Because it's and why is it nice? Because it's a good thickness.
Good thickness.
There's
And you should have...
strata's quite.
Yeah, you should have echogenic borders, just like that, and then normal thickness, and then it's sort of normal sort of level echoes, lower level echoes in the middle there. It's lovely. But of course, your plantar fascia goes into different bands. So all we're doing is looking at the middle band there.
Right, yeah.
So your middle bit's lovely.
It's the middle bit. All right. Is that okay?
Yep.
Yeah.